Start with the anatomy. For meniscus tear, the important structures are medial meniscus, lateral meniscus, tibial plateau, femoral condyle, vascular red zone, and a vascular white zone. Do not memorize the picture as a list. Ask what each structure is trying to do when the person moves. In real life, the problem sounds like this: joint line pain, swelling after a twist, catching, and fear that the knee is stuck forever. That story is the doorway into the diagnosis. It tells us which tissues are likely overloaded, irritated, torn, compressed, or failing to share load. The core mechanism is pivoting trauma, degenerative fraying, hoop stress failure, unstable flaps, and root tear load loss. This is why two people with similar images can feel very different. Tissue appearance, load, inflammation, nerves, strength, and confidence all interact. For the lay viewer, the question is not, what word is on the scan? The better question is, what system is failing? For the resident, the question is sharper. What is the pain generator, what is the structural risk, and what can safely wait? A practical way to think about almost every orthopedic problem is tissue capacity versus load demand. If the load is temporarily too high, the answer may be calming and rebuilding. If the structure has mechanically failed, the answer may need repair, reconstruction, replacement, or protection. The common symptoms cluster around joint line pain, delayed swelling, catching or locking, pain with squatting and twisting. Symptoms matter most when they form a pattern. One symptom by itself can mislead. A cluster is much more useful. Listen for timing, load, swelling, night pain, mechanical symptoms, and whether the person is losing trust in the limb. Also listen for what the problem has taken away: sleep, walking, work, sport, independence, or confidence. The best history is not a questionnaire. It is a map of what loads reproduce the problem, what settles it, and what function is disappearing. The exam should not be random. For this topic, deliberately check joint line tenderness, a fusion, McMurray pattern, loss of extension suggesting a displaced tear. A good exam separates pain from weakness, stiffness from fear, and joint disease from referred pain. For patients, the important idea is that touching one sore spot is not the same as understanding the whole problem. For residents, every test should answer a question that changes management. If a test is painful but does not change your plan, it is theater, not medicine. Good examination